Diagnostic imaging. Conventional MRI magnetic resonance imaging is the most important imaging study for astrocytomas. Usually, images are acquired both before and after the administration of IV contrast. As a rule of thumb, if the tumor picks up the contrast, it is an indication of higher grade astrocytoma. Other imaging sequences provides clues as to tumor cellularity, brain swelling, or brain infiltration. MRI spectroscopy. It is an imaging tool based on MRI which provides information on the chemical composition of the tumor and works based on the fact that certain chemicals are abundant in the normal brain. The output of this imaging modality is a diagram showing the amount of each chemical in the area of the brain under analysis. If the amount of NAA is more than chlorine, that suggests a normal brain, the opposite raises suspicion of a tumor. This technique can be considered as a non-invasive tissue sampling, although it is not as accurate or definitive as a standard biopsy. Functional MRI. fMRI, it is a useful technique used to visualize in real time which parts of the brain become activated when the patient is asked to perform a certain task. This is fundamental to define the regions of the brain which, if damaged, would cause problems to the patient. Activated brain is shown as a yellow or a red signal superimposed to an otherwise standard MRI. Treatment. Surgery. Surgery is the first step for the treatment of astrocytomas as it provides two important benefits. First, it procures tumor tissues to establish a diagnosis. Secondly, it offers the possibility to remove as much as tumor as safely as possible to relieve mass effects, reduce swelling, and facilitate response to adjuvant therapies when indicated. Important tools to maximize efficiency and safety of surgery are neuronavigation. It is in essence a GPS system for the brain and allows the surgeon to visualize in real time on the MRI his or her localization with the patient's brain. Awake surgery. The technique is particularly useful to resect tumors located in speech areas and also when close to primary motor cortex bilaterally. The patient is kept sedated but not intubated so that he or she can speak and execute commands when asked to. Motor mapping during general anesthesia. The regions of the brain controlling movement can also be stimulated with an electrode even if the patient is asleep. A stimulator is used to apply currents directly to the brain cortex and muscles response are recorded. Fluorescent dyes. Tumors, particularly those of higher grade, have the characteristic to avidly absorb certain dyes that are given IV to the patient just before surgery. In this way, the tumor tissue becomes colored by the specific dye while the normal brain does not. This allows a much more precise definition of what should be resected and what should be left untouched. Established adjuvant therapies. Steroids. Dexamethasone is a drug of choice to relieve symptoms due to the brain swelling that is often associated with the tumor. It is a very effective drug which acts quickly and reliably. Unfortunately, it does not have any action against the tumor and is associated to the significant side effects when used for periods longer than 2 to 3 weeks. Chemotherapy with TMZ. TMZ is a drug which is taken by the mouth and works slightly modifying the DNA of tumor cells. This effect on DNA triggers the breakage and consequent death of the cell unless DNA repair mechanisms override the damage. Radiotherapy. Radiation has been the basis of treatment of astrocytomas for the past 50 years and is extremely effective. At least for the first few months after treatment, radiation too works by damaging the DNA of the tumor. Avastin. Avastin is a drug that blocks the tumor ability to recruit blood vessels so that they can feed themselves and keep growing. Tumor treating electrical fields. In 2011, the FDA approved the use of a special device applied to scalp as helmet, which produces low current electrical fields which have been proved to delay tumor growth. Anti-seizure drugs. Keppra is the most widely used drug for this purpose. Experimental therapies. Astrocytomas and in particular glioblastomas are the target of intense research, and every year several clinical trials are conducted to find new strategies which would improve survival. Targeted therapies. Nowadays, the majority of treating centers perform detailed genetic analysis of any tumor tissue removed with surgery in order to obtain patient-specific molecular signatures which can help establish the best drug for that tumor. Immunotherapy. Weakened immune surveillance is fundamental for the development and progression for astrocytomas. For this reason, a large effort is currently underway to find strategies to boost the immune system against the tumor. Virus therapy. A promising and ever expanding approach is the use of viruses, which, once administered to the patient, can selectively infect and destroy the tumor cells without harming the surrounding normal brain. Prognosis. The major factors determining the length of survival after a diagnosis of astrocytoma are the following. Tumor grade or histology. Grade 1 tumors are largely cured. Grade 2 tumors, overall median survival is 8 years. Presence of IDH1 mutation is associated with longer survival. Grade 3 tumors, median survival is 3 to 5 years, and grade 4 tumors, median survival is 15 months. Extent of surgical resection. Although complete microscopic resection of grade 2 to 4 tumors is impossible due to their diffuse infiltration into the normal brain macroscopically, total resection is associated with significantly better survival. Use of adjuvant radiotherapy or chemotherapy. Age. Young age is associated with longer survival. Functional status. Minimal symptoms or normal neurological function are associated with longer survival.